This is a very interesting point in coming from biology of mantle cell lymphoma. It is well known that cyclines play a major role. I mean, everybody knows that cyclin D1 is very important. And it has been clear that in the cell cycle machinery, cyclin D4 and 6 are as important as well. And there is a number of inhibitors of that, and Abemaciclib is one of those. And so in the early times when this drug had been tested broadly in a variety of diseases, there were some early responses in lymphoma, and especially in mantle cell lymphoma. So there was a phase 2 trial exploring the usability and the efficacy of Abemaciclib in patients with multiple refractory mantle cell lymphoma. I have to say these patients basically rarely have been treated with BTK inhibitors, so it's not the typical totally refractory population we see nowadays, but they had a median of 2 to 3 prior treatment lines. And interestingly enough, indeed, there was some patients who really had substantial responses. So roughly half of the patient had clinical benefit, which turned out to be a 25% overall response rate. Basically, most of these responses seen were partial responses. However, there was quite a good durability in these patients responding, so duration of response was quite good. One of the issues is that the tolerability had been a little problematic, especially fatigue and diarrhea had been present in these patients, nausea, vomiting. So it looks like that either the dosage schedule would need to be adopted, or that there would be kind of an on-off treatment, which might be a good idea. So finally, and it's the same story with Palbociclib, which is an inhibitor of the cyclines as well. There is good efficacy, but it looks like that probably the single agent use is not the best way to go, and it would be very interesting to see if we can do it in a combination fashion. And Peter Martin is doing a combination of BTK with a cyclin inhibitor, just demonstrating that he could overcome BTK resistance by that approach. So in general, I believe that these drugs might be helpful, but with limited number of patients affected, and thereby always having small trials, it would be very complicated these days to define the optimal use. And I believe at this time it's probably more a reserve strategy than that it will be one of the major drivers of first and second line treatments in the future.